Good morning, everybody. I will present uncommon presentations of a common disease. So this case has two parts. One is 22. Both young people came in same week. This is a 22-year-old male, blurring of vision 5 days, history of fever, no systemic disease, vision 6/60. This is the fundus picture. You can see an area of something like vitreous was a little hazy due to vitreous cells. Sheathing is there, here it is visible nicely. Little more increase. Vascular sheathing is there and vitreous cells are there, and there's a retinoporoiditis patch. This is the other eye. Here also you can see some sheathing. This is the lesion. This is the angiogram. This is the angiogram showing sheathing and leakage. Periphery also, bilateral vasculitis. Nothing, Mantu was negative, Toxo was negative, ESR was normal. So we were thinking about retinal vasculitis, toxoplasma, etc. and treated with steroids, vision improved. This is, little more, can you brighten this? This is pre-treatment and post-treatment. OCT before and after treatment. Now this is the main case that I am coming into. This is another boy, another man, 39-year-old, defective vision of right eye of 1 week duration, no systemic diseases. This is the finding. You can see similar yellowish subretinal lesion inferiorly, but vitreous is very clear. Left eye is looking normal, nothing much. So these are the two cases. This is the first case where there is a lesion like this. This is the second case. Here there is vascular sheathing, vitreous slightly hazy. Here it is reasonably clear. So you can compare and confuse. Here also most of the preliminary tests were negative, and this was also diagnosed or rather misdiagnosed as toxoplasma and gave steroids. After 1 week, much better fundus. That lesion here is gone, yellow lesion is gone. This is the finding. But to our surprise, there was an inferior retinal detachment, exudative RD. And then we did an OCT and all, and it is a case of steroid induced or steroid worsened central serous chorioretinopathy. This autofluorescence is very characteristic of central serous chorioretinopathy, hyper-autofluorescent areas, tract and all. So this basically I wanted to show that steroids can be given, mistaking it for retinoporoiditis. And we have given stop steroids and gave placebo. After 2 months, the inferior retinal detachment gradually settled. So these are the points, basically, how you differentiate actual inflammatory vasculitis or retinoporoiditis from a fibrin CSR. This is actually fibrin. Usually this will be seen, fibrin CSR we are all aware of, it is usually seen in the macular area. We don't see fibrinous exudates in the periphery outside the arcade. So that was the main cause of mistaking this for a retinoporoiditis. And so this take-home message probably is careful fundus examination using indirect ophthalmoscopy and slit lamp microscopy. Look for vitreous cells, and if you start by mistake systemic steroids, review after 5 to 7 days always, and see indirect ophthalmoscopy. And so this is one case of central serous chorioretinopathy treated with steroid and worsened. So this is now coming to case 2. This is a 53-year-old man, defective vision of left eye of 1 week duration, and he is a diabetic. Visual acuity was 6/9 and 6/36, right eye, left eye. So this is the fundus photo and fluorescent angiogram. This is the right eye. This is a CSME case where there is NPDR changes. Fluorescent angiography shows leaking microaneurysms, and typical NPDR CSME. This is the left eye. Another left eye also NPDR cases, NPDR with CSME. But OCT showed a lot of fluid in the macula in the left eye, serous macular detachment in the left eye. Okay, the right eye has more of spongiform edema, little serous macular detachment, but left eye, a lot of fluid. Then we did a fundus autofluorescence, and we saw that hyperautofluorescent area along the macula, temporal to the macula, inferior, here also. This has an underlying central serous chorioretinopathy also. That could be the cause for the large serous macular detachment. Go back, then we will see that this point is leaking profusely. It is not a microaneurysm. This point, while the other points are looking microaneurysms. So in fact, there is a point leak also with a superadded diabetic retinopathy. So in fundus autofluorescence is a very useful imaging in CSCR, and this hyperautofluorescence due to fluorophores in the disrupted photoreceptors in the subretinal space results in this hyperautofluorescent area, which can be very useful in the diagnosis of central serous chorioretinopathy. So CSR can coexist with other diseases, and large serous macular detachment in OCT may have to be treated with suspicion. You have to do this test to rule out any this thing. Intraretinal edema usually will be absent in pure CSCR, and fundus autofluorescence is a useful investigation. This is the take-home message from this case. Now going to the third case. This was a 74-year-old gentleman referred as a case of macular degeneration. Visual acuity was 6/24 and 6/60, right eye, left eye. So this is fundus picture, lot of RP modeling, and degenerative changes are there. Looks like dry ARMD considering the age, 74 years. This is the fluorescein angiogram, RP window defects, and this looks like a pooling of dye in the PED and staining of some drusen. The OCT showed cystoid edema, disruption of ellipsoid line, and in the right eye. Left eye has foveal atrophy. This clinches the diagnosis. He had RP tract in the left eye. Right eye also has hyperautofluorescent area in the macula. So the patient is not having dry ARMD. He had old CSR, central serous chorioretinopathy sequelae. AMD is not the take-home message is AMD is not the only macular degeneration in elderly, and we should remember that CSCR patient can also get aged, and CSR sequelae can be seen in elderly. Since and the treatment of both entities are different before labeling him dry ARMD. Thank you for the kind attention.